Thank you, Angeliki. Thank you, Mrs. Chair, dear colleagues, dear participants, and above all other things, dear friends. It gives me a great pleasure to use the next couple of minutes to present you with the results of our surveillance of adverse events following immunizations. Without any doubt, immunizations and vaccines are the most successful public health story ever. Only due to vaccines and by the virtue of vaccines, we have successfully eradicated smallpox, and we have never ever been closer to eradicating another communicable disease, and that is polio. Unfortunately, it seems that fear of the communicable diseases and high incidence of communicable diseases is not driving force for immunizations around the world. This is especially applicable for the immunization processes in developed countries and in the modern era. It seems, and the scientific evidence shows, that safety of the vaccines is getting more and more important, and some scientists say that it is the most important determinant in deciding whether to vaccinate or not. In the same time, we are facing with the various problems. For the instance, design of clinical trials of vaccines are lacking in terms that they are not providing us with possibility to detect very rare events following immunizations, and therefore post-marketing surveillance and passive surveillance of adverse effect following immunizations is crucial. This is probably best described by Chen in the famous paper back in the 90s. He described the living cycle of immunization program that starts with high incidence of communicable disease, followed by the introduction of effective vaccine. As the vaccine coverage grows up, incidence of the disease goes down. At the same time, increasing coverages is followed by increase in adverse events following immunizations, both in terms of number and public perception of them. This increase of adverse events is necessarily leading to one very important thing, and that is the loss of confidence in the immunization program, which by itself is followed by two very important occasions. First one is the lowering of the incidence of adverse events following immunizations, and what is the most important thing, that's the outbreak of the communicable diseases. Outbreaks by themselves have big influence on the immunization programs by the resumption of confidence in the immunizations, but our task and our duty as public health officers is not to have the outbreaks leading our immunization programs, and not having outbreaks needed to resume the confidence in the immunizations, but it is the surveillance of adverse events following immunizations. Having all this in mind, we have set the primary objective for our study as to perform the tail descriptive analysis of reported adverse events following immunizations in over 11 years of time, with hopefully and in order to get insight in the safety profile of the vaccines that were used in Montenegro. At the same time, we also defined secondary objectives of the study, and those were to provide evidence and improve awareness of the vaccine safety, to increase transparency in AEFI surveillance, and which is very important, to compare the surveillance results of our surveillance system with other similar systems in the world. Having that in mind, we designed a retrospective descriptive study that was based on passive, nationwide, mandatory surveillance system of adverse events, which was based on a form that was prescribed and defined in our bylaws. At the same time, we used WHO case definition for adverse event, which is actually any kind of unwanted medical occurrence or event that follows immunizations and which is not necessarily related in any kind of causal relationship with the immunizations and vaccines themselves. Regarding the results, in this period of time, we received only 251 reports of adverse event following immunization, which, when we subtracted with the total number of doses distributed, gave us overall AEFI rate of 11.2 over 100,000 doses distributed. In terms of annual trends, they showed significant annual variations from year to year, and mostly these were influenced by two factors. First one was the introduction of acellular pertussis vaccine back in 2011, which significantly dropped the incidence of AEFI rates, and also intensive continuous medical education that started in 2015 had the influence on increasing number of events being reported. In terms of demographics, we observed no statistically significant difference between male and female. And when it gets to age, although number of reports was the same in the first and second year of life due to the immunization schedule, and when we calculated age group specific rates were highest in the second year of life, and then followed by the preschool children aged 3 to 6. In terms of the vaccines, the type of vaccines, most commonly reported adverse effects were following whole cell pertussis vaccine, with almost 40% of reports being related to this vaccine, then followed by MMR, DT, and TT in absolute numbers, but looking at the rates, BCG was slightly higher than TT vaccine. Annual trends for the first top three antigens, top 3 vaccines were such. And in 2010, we've seen a peak that was related to a single product of whole cellular pertussis vaccine. Regarding MMR, trend was stable, as we expect. And regarding DT, we had an increase back in 2016. When it gets to the types of AEFI, we've subtracted them by local, systematic, and both. And important to notify and to notice here is the frequency of hospitalizations as an indicator of the severity of the outcome. Majority of systemic, actually only systemic reactions required hospitalization, and 23.7%, almost 1/4 of systemic reactions were followed by hospitalization. This also indicated us the need for thorough analysis of systemic adverse events, and by structuring them, we realized that the fever was the most common one, with the incidence or rate of 4.1, and with all the others that showed no statistically significant differences. In terms of vaccines and the type of AEFI, we've noticed following things. First, majority of the fever was related to DTP vaccine. MMR only caused systemic reactions, and actually reactions following MMR were in 85% of systemic nature. And when it gets to DT, vast majority of them, more than 80% of reactions following DT were local. But also, when it gets to DT, we've notified one allergic reaction of severe nature. We had reported one anaphylaxis following the DT vaccine, which is giving us an overall rate of 1/2.2 million doses, which is in accordance with the literature. Regarding the causality assessment, our National Board for Causality Assessment of AEFIs classified vast majority, 70% of the reports as being certain and related to the specific vaccine product. When it gets to the overall analysis of our study, it is very important to say that this was the first study of this kind in our country. And therefore, we did truly our best to eliminate all the possible limitations and any weak points and bottlenecks of the study. Of course, we failed to do that in some of the instances, and mostly those instances were regarding the lack of information or background rates of these events, and also some limitations were referring to the passive surveillance system as it is. Regarding the results, it seems that reporting has been biased by various and many factors. Annual variations might be dependent on the type of the final product, which is actually limiting the study and the studies of this kind in terms of comparison, because the only circumstances in which results can be compared with international studies are if the systems are the same, if the vaccine schedule is the same, and if the product used is, of course, the same in the two systems. Nevertheless, our overall rate of AEFIs was higher than reports from other countries, which suggests that our system is sensitive enough to detect adverse events following immunizations. Although mandatory, reporting might be the problem, as in every passive surveillance systems, and we've focused on our findings in order to find the room for further improvement of the surveillance system. Therefore, we have developed recommendations, in some of which include possibility for general public to report adverse events following immunizations, and I'm very happy to say that the results from this study directly influenced National Regulatory Agency to include public reporting of AEFIs beginning from the 1st January of 2018. Of course, with the problems and bottlenecks identified, we do believe that more standardized approach is needed with clear case definition of every single event, not just the global comprehensive definition. We need clear guidance on AEFI surveillance, and we have developed them, and they will also came to force beginning January 1st. And finally, continuous work on improvement of AEFI surveillance is of utmost need. And finally, last but not the least, I would like to express my acknowledgements to all of you, to all of my friends and fellows who did the critical analysis of the presentation and our work in the review module in SPECES. And also I would like to thank to my scientific coordinator and country coordinator who couldn't be present here today with you. Thank you very much.
Thank you, Senad. That was an excellent presentation. Before we comment something, I would like to open the floor for questions. Yes, Nada?
Good morning. Very nice presentation. Did you have any death?
No, death hasn't been recorded and hasn't been reported following the immunization.
Did you have any severe complications?
No, all of the children got, all of the children who were hospitalized, the ones that were shown here, had what we call restitutio ad integrum, which means that following the hospitalization, they were sent to their homes, and no information during the follow-up we received about any kind of chronic complications and consequences.
Do you plan to have compensation in case of severe complication?
I'm afraid I didn't understand you.
Compensation.
Oh, yes, thank you very much. That is a big, big question. Yes, we do plan to establish a fund, but it seems that the communicating about the fund and about the compensation about the vaccine injury, it's very, very difficult and very demanding in many aspects and in many ways, because it has been the fact that it has been abused on so many occasions by various anti-vaccinational movements throughout the world, as they have been using it as a kind of a proof among themselves that vaccines do cause injuries, and therefore the fund is made for that. As you know, American fund was the first one to be established in the world. It happened back in the 80s as a measure of reestablishing trust in, first of all, pertussis immunization program, and it remained since the 80s. We have plans. Is it going to be difficult? Yes, it is. How we are going to communicate it, I don't know. How we are going to communicate with the lay public that that fund is meant to compensate for the obligatory status of vaccines in our country, we will have to see that.
Good presentation. I would like to know who are the nodal officers at the peripheral level for this data collection, for reporting these adverse events. One thing, nodal officers for reporting these events at the peripheral levels.
Okay.
One question. And another one is, like, other than this routine vaccination, were there any supplementary immunization activities going on, and how it was differing from the routine vaccination?
I would have to ask you to go question by question, if you don't mind.
Just two questions.
So, yeah, thank you very much. Thank you very much. Very good questions. First of all, Montenegro is really, really small country compared to India. Our population is 625,000. And we have very well established electronic immunization records, and the adverse events following immunizations in the last couple of years have been reported electronically in the real time. And reporting is being done by every single physician working in the country. So all of the physicians, pediatricians, GPs, all the others, all the specializations have the possibility to report it either through electronic form or through the paper-based form that's described earlier. So the coverage is comprehensive. 100% of healthcare workers have been covered by the system, and I do believe that is the answer to the first question. I would kindly ask you just to repeat the second one.
Other than the routine vaccination, were there any supplementary immunization activity? And what were the adverse events in those?
Supplementary immunization activities are conducted in special populations, hard to reach, very mobile populations, displaced populations, because we had a lot of refugees starting from 2000 and onwards. But most of the refugees are very well integrated in our society. So in the last couple of years, those supplementary activities are conducted throughout the year, but covering only small amounts and small pockets of unvaccinated and hard to reach children. And all of those doses are included here as being distributed and are included in the denominator. So the system and the results shown here cover it all, regular and supplementary immunization activities.
Okay, just one question. Yeah, Hala?
Thank you for your presentation. I have a question. I'm wondering, for those neurological adverse events, were they included as an AFP case?
Yes. As you could have seen, we've done the analysis on the allergic and neurological reactions because that is the approach being used in the literature, as the systematic adverse events are usually classified in several groups, and the neurological reactions included here were convulsions, paresis, and paralysis, and encephalitis. So that was the definition of neurological adverse events, and they were included in the study.
Thank you so much.
Okay, thank you. Actually, we have not a lot of time, but I wanted to ask you if you have observed any hesitancy effect in your country, and if yes, for which vaccine?
Yes, unfortunately, but yes. We are at the moment at the lowest point of our vaccination coverage ever, especially regarding the MMR. As a matter of fact, MMR is the only problem in our immunization system, and during the last year, and birth cohort of 2015 was vaccinated, believe it or not, with only 47.6%, which is shameful for the heart of the Europe. But when it gets to the other vaccines, we have tremendous coverage with DTP3, for instance. We have electronic immunization records that is in real time. For instance, coverage with DTP3 for the same birth cohort was above 90, and DTP1 was 99%, which seems that hesitancy is only focused on the MMR and the alleged connections between MMR and autism. We've done a lot, we're doing a lot, and we do believe that the results of this study, and especially the transparency of adverse events following immunizations, will help us regain the public trust when it gets to MMR. For instance, rate of anaphylaxis following some kind of macrolide. Anaphylaxis, I mean anaphylactic and anaphylactic-like reactions, is 1/250 given doses. 250, and we've received only one anaphylaxis on 2.2 million doses distributed, which definitely indicates the safety of the vaccine is the highest in all of the pharmacy and regarding all the drugs and products.
Thank you, because it's always challenging when you have to communicate the results of such surveillance and adverse effects, because that might also cause the hesitancy effect, but as you said, we need to be transparent, and most of the times it's going to be beneficial. But we need to find, I guess, a way to do it efficiently, yes, that we don't alert the public for no reason. Okay, thank you, Senad.
Totally agree. Thank you.
Thank you.